Question 1. A patient is admitted to the hospital with acute abdominal pain, nausea, and vomiting. After diagnostic workup, the final diagnosis is acute appendicitis. The patient undergoes an appendectomy. Which condition should be reported as the principal diagnosis for this inpatient encounter? A. Nausea and vomiting. B. Acute abdominal pain. C. Acute appendicitis. D. Post-operative pain. Answer: C. Acute appendicitis. This question tests the concept of determining the principal diagnosis for an inpatient stay. The key clues are inpatient encounter and principal diagnosis, which refer to the condition chiefly responsible for the admission to the hospital. Although the patient presented with symptoms like pain, nausea, and vomiting, these were indicators of the underlying condition, acute appendicitis, which was ultimately diagnosed and treated. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. For example, if a patient comes in with chest pain and is diagnosed with a heart attack, the heart attack is the principal diagnosis. Remember that the principal diagnosis is the reason the patient was admitted, not just their symptoms. Question 2. A 45-year-old male presents to the physician's office for a routine annual physical examination. During the same visit, he also expresses concerns about a new rash on his arm, which the physician evaluates and diagnoses as contact dermatitis. What is the correct way to report the evaluation and management (E/M) services for this encounter? A. Report only the routine annual physical examination code. B. Report only the code for the contact dermatitis evaluation. C. Report both the routine annual physical examination code and the appropriate E/M code for the contact dermatitis with modifier 25 appended to the E/M code. D. Report both the routine annual physical examination code and the appropriate E/M code for the contact dermatitis without any modifier. Answer: C. Report both the routine annual physical examination code and the appropriate E/M code for the contact dermatitis with modifier 25 appended to the E/M code. This question addresses the coding of preventive services when a significant, separately identifiable E/M service is performed during the same encounter. The key phrase, during the same visit, indicates that two distinct services occurred. When a problem-oriented E/M service is performed in addition to a preventive E/M service, and the problem-oriented service is significant and separately identifiable, both services may be reported. Modifier 25 must be appended to the problem-oriented E/M code to indicate that a significant, separately identifiable E/M service was performed on the same day as another E/M service. For instance, if a patient has their annual checkup, preventive, and also gets a new mole evaluated, problem-oriented, during the same visit, both can be billed. Always remember that modifier 25 tells the payer that the two E/M services were distinct and not part of the bundled preventive service. Question 3. A coder is abstracting an inpatient record for a patient admitted with severe pneumonia and acute respiratory failure. The documentation clearly states acute respiratory failure due to severe pneumonia. How should these conditions be coded? A. Code only the severe pneumonia. B. Code only the acute respiratory failure. C. Code severe pneumonia first, followed by acute respiratory failure. D. Code acute respiratory failure first, followed by severe pneumonia. Answer: D. Code acute respiratory failure first, followed by severe pneumonia. This question tests the understanding of coding conditions that have a due-to relationship, specifically when a manifestation, like acute respiratory failure, is caused by an underlying condition, like pneumonia. The keyword due to indicates a causal link. When a diagnostic statement indicates that one condition is due to another, the manifestation, the condition that results, is typically sequenced first, followed by the underlying etiology. In this scenario, acute respiratory failure is a manifestation of the severe pneumonia, therefore acute respiratory failure is sequenced as the principal diagnosis, followed by the pneumonia. It is crucial to follow the ICD-10-CM coding guidelines for code first and use additional code notes, as these specify the correct sequencing. Question 4. In ICD-10-PCS, which root operation involves taking out or off a portion of a body part without replacing it, to eliminate the entirety of a body part? A. Excision. B. Resection. C. Extraction. D. Detachment. Answer: B. Resection. This question assesses knowledge of ICD-10-PCS root operations, specifically differentiating between similar-sounding terms. The key phrase, taking out or off a portion of a body part without replacing it, to eliminate the entirety of a body part, points directly to the definition of resection. Resection involves removing an entire body part, or all of a specific body part, whereas excision involves removing only a portion of a body part. For example, removing an entire lobe of the lung would be resection, while removing a small tumor from the lobe would be excision. Understanding the precise definitions of root operations is critical for accurate ICD-10-PCS coding. Question 5. A patient is seen for follow-up of a scar on their arm resulting from a burn sustained 2 years ago. The scar is causing some discomfort but is not actively infected or healing. Which type of code should primarily be used to describe the scar in ICD-10-CM? A. An acute burn code. B. A current complication code. C. A late effect code. D. An external cause code. Answer: C. A late effect code. This question focuses on the appropriate coding for conditions that are residual effects of a past illness or injury, known as late effects. The key phrase, resulting from a burn sustained 2 years ago, clearly indicates that the current condition, the scar, is a residual effect of a healed, previous injury. Late effects are conditions that occur after the acute phase of an illness or injury has terminated. For late effects, 2 codes are generally required. The first code describes the residual condition, the scar in this case, and the second code describes the late effect, indicating the cause of the residual condition. Remember, if a patient has a condition like paralysis from a stroke that occurred years ago, you code the paralysis as the current condition and the stroke as the late effect. Question 6. Which of the following statements best describes the purpose of HCPCS Level 2 codes? A. To report physician services and outpatient procedures. B. To describe durable medical equipment, prosthetics, orthotics, and supplies. C. To classify diagnoses and inpatient hospital procedures. D. To identify drugs administered in an inpatient setting. Answer: B. To describe durable medical equipment, prosthetics, orthotics, and supplies. This question tests the understanding of the specific purpose and scope of HCPCS Level 2 codes. The purpose of HCPCS Level 2 codes is to report services, supplies, and durable medical equipment that are not covered by CPT codes. It encompasses items such as ambulance services, prosthetics, orthotics, and certain drugs administered outside of the physician's office. For example, if a patient receives a wheelchair or specific medical supplies, those items are typically reported using HCPCS Level 2 codes, not CPT codes. Think of HCPCS Level 2 as the coding system for everything else not found in CPT, particularly for non-physician services and supplies. Question 7. A coder notices that a physician's documentation consistently uses abbreviations that are not on the hospital's approved abbreviation list. What is the most appropriate action for the coder to take? A. Code the encounter based on the coder's best interpretation of the abbreviations. B. Use the unapproved abbreviations but add a note to the chart. C. Query the physician for clarification of the documentation. D. Report the physician to hospital administration for noncompliance. Answer: C. Query the physician for clarification of the documentation. This question addresses the importance of clear and complete documentation for accurate coding and the process for resolving ambiguities. The key issue here is the use of unapproved abbreviations, which can lead to misinterpretation and inaccurate coding. When documentation is unclear, ambiguous, or contains conflicting information, the coder's responsibility is to query the provider for clarification. Coding based on interpretation or assumption is unethical and can lead to errors. For example, if SOB could mean shortness of breath or status post-bypass in different contexts, the coder must ask the physician to clarify. Always remember that if you're unsure what the provider means, the best course of action is always to ask for clarification. Question 8. According to UHDDS, Uniform Hospital Discharge Dataset, Guidelines, which of the following best defines other diagnoses? A. All conditions that coexist at the time of admission, or develop subsequently, which affect the treatment received or the length of hospital stay. B. Diagnoses that are ruled out during the inpatient stay. C. Diagnoses that are suspected but not confirmed. D. Diagnoses that are historical and have no bearing on the current admission. Answer: A. All conditions that coexist at the time of admission, or develop subsequently, which affect the treatment received or the length of hospital stay. This question tests the understanding of key definitions within the Uniform Hospital Discharge Dataset, UHDDS, which provides definitions for terms used in the acute inpatient setting. The definition of other diagnoses is crucial for accurate inpatient coding. These are conditions, besides the principal diagnosis, that either existed at admission or developed later, and significantly influenced the patient's care, such as requiring clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of hospital stay, or increased nursing care and monitoring. For example, if a patient is admitted for pneumonia but also has uncontrolled diabetes that requires management during the stay, the diabetes would be an other diagnosis. It is important to distinguish these from conditions that were merely evaluated and ruled out, or historical conditions not affecting the current stay. Question 9. A hospital's coding compliance plan should ideally include which of the following components? A. A disciplinary process for non-compliance, but only for physicians. B. Regular coding audits and monitoring, and a process for corrective action. C. A system for coders to appeal denied claims without review. D. Only a statement that coders must follow official coding guidelines. Answer: B. Regular coding audits and monitoring, and a process for corrective action. This question focuses on the essential elements of an effective healthcare compliance plan, specifically concerning coding. A robust compliance plan, as mandated by regulatory bodies, includes systematic processes to ensure adherence to rules and regulations. Key components include ongoing education and training for coders, regular internal and external audits to identify errors, and a clear process for addressing and correcting any identified noncompliance, which fosters accurate and ethical coding. Simply stating rules or having an incomplete disciplinary process is insufficient for a comprehensive plan. For example, a good plan would involve quarterly reviews of coded charts, identifying common errors, and then providing targeted training to prevent recurrence. A strong compliance plan proactively identifies and addresses issues to maintain billing integrity. Question 10. According to CPT guidelines, the surgical global package typically includes which of the following services? A. All E/M services provided by the surgeon for 90 days before and after the surgery. B. The operation itself, local anesthesia, and routine follow-up care for a specified period. C. All hospital inpatient charges, including room and board. D. All services provided by all physicians involved in the patient's care. Answer B. The operation itself, local anesthesia, and routine follow-up care for a specified period. This question tests knowledge of the CPT surgical global package, a fundamental concept in surgical coding and billing. The global surgical package bundles together the operation, necessary local anesthesia, and routine preoperative and postoperative care provided by the surgeon into a single payment. It does not include services unrelated to the surgery, services provided by other physicians, or all hospital charges. For example, if a surgeon performs an appendectomy, the fee typically covers the surgery itself, any minor dressings, and follow-up visits for the typical postoperative period, e.g., 90 days. Understanding the global package helps prevent unbundling and ensures accurate reimbursement. Question 11. A patient presents with chronic obstructive pulmonary disease, COPD, and is experiencing an acute exacerbation. In ICD-10-CM, how is this condition typically coded? A. Code only the acute exacerbation. B. Code only the chronic obstructive pulmonary disease. C. Code the chronic obstructive pulmonary disease with acute exacerbation, if a combination code exists. D. Code chronic obstructive pulmonary disease and a separate code for acute exacerbation. Answer C. Code the chronic obstructive pulmonary disease with acute exacerbation, if a combination code exists. This question addresses the coding of chronic conditions with acute exacerbations in ICD-10-CM. The keyword acute exacerbation indicates a worsening of a chronic condition. For conditions like COPD, asthma, or heart failure, ICD-10-CM often provides a single combination code that fully describes both the chronic condition and its acute exacerbation. This practice aligns with the guideline to use a single code when it fully expresses the diagnostic statement. For example, instead of coding chronic asthma and then acute exacerbations separately, ICD-10-CM has a specific code for J45.901 unspecified asthma with acute exacerbation. Always look for specific combination codes when a chronic condition is stated with an acute exacerbation. Question 12. A patient is seen in the outpatient clinic with symptoms of a viral infection, and the physician documents probable viral pneumonia. How should this diagnosis be coded in the outpatient setting? A. Code viral pneumonia as if it were a confirmed diagnosis. B. Code the symptoms only, as the diagnosis is not confirmed. C. Query the physician for clarification. D. Code viral infection, unspecified. Answer B. Code the symptoms only, as the diagnosis is not confirmed. This question tests the crucial difference in coding probable or suspected diagnoses between inpatient and outpatient settings. The key phrase outpatient setting is critical here. In the outpatient environment, diagnoses documented as probable, suspected, questionable, or rule out are not coded as if they are confirmed. Instead, the coder should report the signs, symptoms, or abnormal findings that led to the visit. For example, if a patient has suspected strep throat but the test is pending, you code the sore throat and fever, not strep throat. This guideline ensures that outpatient claims reflect only confirmed conditions and avoids billing for services not definitively provided for a specific diagnosis. Question 13. Which of the following medical terms refers to inflammation of the liver? A. Nephritis. B. Gastritis. C. Hepatitis. D. Arthritis. Answer C. Hepatitis. This question assesses basic medical terminology, specifically focusing on suffixes. The concept being tested is the ability to recognize common medical roots and suffixes to understand their meaning. The suffix itis consistently means inflammation, and the root hepat/o refers to the liver. Therefore, hepatitis accurately translates to inflammation of the liver. For instance, nephritis refers to kidney inflammation, nephr/o, gastritis refers to stomach inflammation, gastr/o, and arthritis refers to joint inflammation, arthr/o. Knowing these common prefixes, roots, and suffixes can help you decipher many medical terms. Question 14. A patient is admitted to the hospital for observation due to chest pain, but after a thorough workup, all cardiac causes are ruled out, and the patient is discharged with a diagnosis of nonspecific chest pain. What is the appropriate principal diagnosis for this inpatient encounter? A. Chest pain, unspecified. B. Observation for suspected cardiac condition. C. The most severe symptom the patient experienced. D. A Z code indicating encounter for observation for other specified suspected conditions. Answer: A. Chest pain, unspecified. This question examines the correct principal diagnosis selection when a patient is admitted for observation or evaluation, and the suspected condition is ruled out. The key phrase, all cardiac causes are ruled out, indicates that the reason for the admission was not confirmed. In such cases, if the patient is admitted for observation of a suspected condition that is subsequently ruled out, the principal diagnosis assigned should be the chief complaint or symptom that occasioned the admission. For example, if someone comes in with severe headaches but no specific neurological condition is found, the headache is the principal diagnosis. This guidance ensures that the billed services reflect the actual reason for the patient's presentation and subsequent care. Question 15. A patient is admitted to the hospital due to respiratory depression caused by an overdose of prescribed Xanax. The patient intentionally took more than the prescribed dosage. How would this be coded in ICD-10-CM? A. Adverse effect of Xanax, followed by respiratory depression. B. Poisoning by Xanax, accidental, followed by respiratory depression. C. Poisoning by Xanax, intentional self-harm, followed by respiratory depression. D. Underdosing of Xanax, followed by respiratory depression. Answer: C. Poisoning by Xanax, intentional self-harm, followed by respiratory depression. This question tests the distinction between adverse effects, poisoning, and the intent of a drug-related event. The keywords overdose of prescribed Xanax and intentionally took more than the prescribed dosage are crucial clues. When a drug is taken in excess of the prescribed dosage, it is considered a poisoning, not an adverse effect. Furthermore, intentionally took more signifies intentional self-harm. Therefore, the primary code should be for poisoning by the specific drug with the correct intent, intentional self-harm, followed by a code for the manifestation, respiratory depression. For example, if someone accidentally takes too much of their blood pressure medication, it's an accidental poisoning. If they take it to harm themselves, it's intentional. Always determine the intent when coding drug-related issues. Question 16. In the Hospital Inpatient Prospective Payment System, IPPS, what is the primary purpose of diagnostic-related groups, DRGs? A. To determine physician reimbursement for surgical procedures. B. To classify inpatient hospital stays into groups that are medically similar and consume similar resources. C. To track the quality of care provided in outpatient clinics. D. To categorize services for individual patient billing at the charge master level. Answer: B. To classify inpatient hospital stays into groups that are medically similar and consume similar resources. This question assesses understanding of the Hospital Inpatient Prospective Payment System, IPPS, and the function of diagnostic-related groups, DRGs. The The key purpose of DRGs is to group inpatient hospital cases that are clinically coherent and similar in terms of the resources they consume, allowing for a standardized payment amount for each group. This system shifts financial risk to the hospital, encouraging efficient resource utilization. For instance, all patients admitted for a routine appendectomy, regardless of minor variations, will typically fall into the same DRG, leading to a predetermined payment. DRGs are fundamental to how hospitals are reimbursed for inpatient services by Medicare and many other payers. Question 17. Which of the following is considered a primary purpose of the medical record? A. To serve as a legal document for litigation only. B. To support reimbursement claims and provide data for research. C. To store patient information for an unlimited time. D. To primarily facilitate communication between the patient and billing staff. Answer: B. To support reimbursement claims and provide data for research. This question asks about the fundamental purposes of a medical record, which extend beyond simple patient care. The medical record serves multiple critical functions. Beyond directly supporting patient care and communication among healthcare providers, it acts as a legal document, provides data for statistical analysis and research, supports health services management, and is essential for justifying charges and supporting reimbursement claims. For example, detailed documentation of a patient's care, diagnoses, and procedures directly supports the medical necessity for services billed to insurance companies. Remember that medical records are comprehensive documents with many vital roles in healthcare, not just for individual patient treatment. Question 18. According to HIPAA's privacy rule, which of the following scenarios is generally permitted without patient authorization for the use or disclosure of protected health information, PHI? A. Disclosure of PHI for marketing purposes to a third-party vendor. B. Disclosure of PHI to public health authorities for disease control. C. Disclosure of psychotherapy notes to a patient's family member. D. Sale of PHI to researchers without de-identification. Answer: B. Disclosure of PHI to public health authorities for disease control. This question tests understanding of the HIPAA privacy rule, which sets standards for the use and disclosure of protected health information, PHI. The privacy rule outlines specific circumstances under which PHI can be used or disclosed without individual authorization. Disclosure to public health authorities for purposes like preventing or controlling disease, injury, or disability is a permitted public health activity. Most other scenarios, like marketing or selling PHI, generally require patient authorization unless specific stringent conditions for de-identification or limited data sets are met. For example, a hospital can report a confirmed measles case to the local health department without the patient's explicit consent. It is crucial to remember that HIPAA aims to protect patient privacy while allowing for essential healthcare operations and public health initiatives. Question 19. A coder reports multiple individual CPT codes for components of a procedure for which a single comprehensive CPT code exists. This practice is known as A. Upcoding. B. Unbundling. C. Downcoding. D. Modifying. Answer: B. Unbundling. This question defines a common compliance issue in medical coding. The concept being tested is unbundling, which occurs when services that are typically included in a single, comprehensive code are instead reported as separate, distinct codes. This practice is considered improper coding and can lead to overpayment, as it appears to inflate the intensity or number of services provided. For instance, if CPT has a single code for appendectomy that includes opening and closing the surgical site, billing separate codes for the incision, the removal, and the closure would be unbundling. Always strive to use the most comprehensive CPT code available that accurately describes the services performed. Question 20. A patient underwent surgery for a fractured femur. 2 days post-operatively, the patient develops a surgical site infection at the incision site. How should the surgical site infection be coded in ICD-10-CM? A. As a principal diagnosis, as it is the most severe condition. B. As a secondary diagnosis, using a complication code. C. As a late effect of the surgery. D. It should not be coded, as it is related to the initial surgery. Answer: B. As a secondary diagnosis, using a complication code. This question addresses the coding of complications of medical or surgical care. The key phrase, 2 days post-operatively, the patient develops a surgical site infection, indicates that the infection arose as a direct consequence of the recent surgical procedure. When a condition arises as a complication of medical or surgical care, it should be coded as such, typically using specific ICD-10-CM complication codes from categories T80-T88. The original reason for admission, e.g., fractured femur, would still be the principal diagnosis, and the infection would be an other diagnosis or secondary diagnosis. For example, if a patient develops pneumonia after surgery, it's coded as a post-operative complication. Always look for codes that specifically identify complications when they occur due to medical or surgical intervention. Question 21. A 7-year-old child presents to the emergency department after falling off a bicycle on the sidewalk. Which category of codes would be used in ICD-10-CM to describe the circumstances of the injury? A. Activity codes, Y93. B. Place of occurrence codes, Y92. C. External cause codes, V00Y99. D. Injury codes, S00T88. Answer: C. External cause codes, V00Y99. This question tests the understanding of external cause codes in ICD-10-CM. The key phrases, falling off a bicycle and on the sidewalk, describe how and where the injury occurred. External cause codes provide supplementary information about the circumstances surrounding an injury, poisoning, or other adverse event. They are generally never sequenced as the principal diagnosis but are used in addition to codes for the injury itself. For instance, an external cause code would specify that a pedestrian was hit by a car while crossing the street. These codes are vital for injury prevention and public health statistics. Question 22. Which of the following is considered a key component in selecting the appropriate level of an evaluation and management (E/M) service in the outpatient setting, according to 2021 CPT-E/M guidelines? A. The number of body systems examined. B. The medical necessity of the service. C. The total time spent by the physician on the date of the encounter or the complexity of medical decision-making. D. The type of health insurance the patient has. Answer: C. The total time spent by the physician on the date of the encounter or the complexity of medical decision-making. This question addresses the updated criteria for E/M code selection, a crucial change in CPT as of January 1, 2021, and continuing for 2025. E/M code selection for office or other outpatient services is primarily based on either the total time spent by the physician or other qualified healthcare professional on the date of the encounter or the complexity of medical decision-making. This represents a significant shift from previous guidelines that focused on history, examination, and medical decision-making as 3 key components. For example, an extended visit where the physician spends significant time counseling a patient on a complex chronic condition might be coded based on time, even if a physical exam was minimal. This change emphasizes the cognitive work involved in patient care. Question 23. A coder identifies inconsistencies between the physician's progress notes and the discharge summary regarding a patient's final diagnosis. What action should the coder take to maintain data integrity? A. Code based on the progress notes, as they are usually more detailed. B. Code based on the discharge summary, as it is the final document. C. Query the physician to resolve the discrepancy. D. Assign an unspecified code due to conflicting documentation. Answer: C. Query the physician to resolve the discrepancy. This question highlights the importance of data integrity and the coder's role in resolving conflicting documentation. When there is a discrepancy between different parts of the medical record regarding a patient's diagnosis or treatment, it creates an ambiguity that can lead to inaccurate coding and affect data quality. The most appropriate action is always to query the physician to clarify and resolve the inconsistency, ensuring that the codes accurately reflect the patient's condition and care. For example, if one note says pneumonia and another says bronchitis, clarification is needed to select the correct diagnosis. Always remember that coders are responsible for reporting accurate and consistent data, and clarification is key to achieving that. Question 24. What is the primary purpose of risk adjustment in healthcare reimbursement? A. To increase payment for all patients to ensure profitability. B. To predict future healthcare costs of patients based on their health status and demographics. C. To penalize providers who treat high-cost patients. D. To simplify the coding process for chronic conditions. Answer: B. To predict future healthcare costs of patients based on their health status and demographics. This question explains the concept of risk adjustment, which is increasingly important in various payment models. Risk adjustment models are used to estimate the relative costliness of patients, allowing health plans or providers to be compensated fairly for managing populations with varying health statuses. These models adjust capitated payments or other reimbursement rates based on factors like age, gender, and, most importantly, the severity and complexity of a patient's diagnoses. For example, a health plan serving a population with a high burden of chronic diseases will receive a higher risk-adjusted payment than one serving a healthier population. Accurate and complete coding of diagnoses is crucial for proper risk adjustment. Question 25. A patient is documented with controlled hypertension and stable type 2 diabetes. How should these chronic conditions be coded in ICD-10-CM? A. Do not code them if they are controlled/stable. B. Code them as if they are active, even if controlled/stable. C. Use specific codes for controlled or stable if available. D. Query the physician for clarification on whether to code them. Answer: B. Code them as if they are active, even if controlled/stable. This question addresses the coding guideline for chronic conditions that are managed and stable. The concept being tested is that chronic conditions are always coded as long as the patient continues to receive care for them, even if they are well controlled or stable. There are no separate ICD-10-CM codes for controlled or stable chronic conditions. The default is to code the condition as active. For example, if a patient has controlled high blood pressure and stable diabetes, the appropriate codes for essential hypertension and type 2 diabetes would still be assigned. Remember that a patient may be treated for a chronic condition even if their symptoms are currently well managed. Question 26. In ICD-10-PCS, what is the root operation that involves putting in a device that replaces or compensates for a body part? A. Fusion. B. Insertion. C. Replacement. D. Supplement. Answer: C. Replacement. This question tests the understanding of a specific root operation in ICD-10-PCS related to implanting devices. The definition of replacement is putting in or on a biological or synthetic material that physically takes the place of all or a portion of a body part. This differs from insertion, putting in a non-biological device that does not take the place of a body part, or supplement, putting in a device that reinforces a body part. For example, a total hip arthroplasty, where an artificial hip joint replaces the original, would be coded with the root operation replacement. Accurately identifying the root operation is the first and often most critical step in ICD-10 PCS coding. Question 27. What is the primary purpose of patient safety indicators, PSIs, developed by the Agency for Healthcare Research and Quality, AHRQ? A. To compare hospital charge masters across different facilities. B. To identify potential adverse events and complications that patients experience as a result of medical care. C. To rank physicians based on their individual performance metrics. D. To determine the appropriate DRG assignment for inpatient stays. Answer: B. To identify potential adverse events and complications that patients experience as a result of medical care. This question addresses the role of patient safety indicators, PSIs, in quality measurement. PSIs are a set of measures that provide a perspective on quality of care, focusing on potentially preventable complications and adverse events experienced by patients during a hospital stay. They help hospitals identify areas for improvement in patient safety. For example, a high rate of post-operative sepsis or pressure ulcers might indicate a need for process improvement. Accurate and complete coding of diagnoses and procedures is essential for the reliable calculation of PSIs. Question 28. In ICD-10 what is the significance of the word with when it appears in a code title or instructional note? A. It indicates that the conditions must be linked only if the physician explicitly documents a causal relationship. B. It means associated with or due to and implies a causal relationship, unless documentation states otherwise. C. It is merely a conjunction and has no specific coding significance. D. It means the two conditions are unrelated. Answer: B. It means associated with or due to and implies a causal relationship, unless documentation states otherwise. This question highlights a crucial interpretive rule in ICD-10 regarding combination codes. The word with and in, when found in a code title, index entry, or instructional note indicates that two conditions are related to one another in a with or due to causal relationship. This presumed link applies even if the physician does not explicitly state the connection in the documentation, unless the documentation clearly states that the conditions are unrelated. For example, if a code title says diabetic retinopathy with macular edema, the macular edema is presumed to be due to the diabetes unless specified otherwise. This guideline helps coders select appropriate combination codes even when direct causality is not explicitly stated. Question 29. A patient presents to the emergency department and is placed in observation status for 24 hours to monitor chest pain. During this time, diagnostic tests are performed, and the chest pain resolves. The patient is discharged home. How is this encounter typically coded for hospital billing? A. As an inpatient admission, with the chest pain as the principal diagnosis. B. As an outpatient encounter, typically using observation E/M codes. C. The services are not billable because no definitive diagnosis was made. D. Only the diagnostic tests are billable. Answer: B. As an outpatient encounter, typically using observation E/M codes. This question addresses the coding and billing for patients placed in observation status. The key phrase "placed in observation status" indicates that the patient is receiving hospital services for a temporary period to assess their condition, typically for less than 48 hours, without a formal inpatient admission. Services provided during an observation stay are generally considered outpatient services, and specific E/M codes for observation care, e.g., CPT codes 99217 to 99220, 99234 to 99236, are used. For example, if a patient comes in with dizziness and is observed overnight, they are usually discharged from observation, and the hospital bills using Outpatient E/M codes for the observation services. Understanding observation status is vital for accurate hospital outpatient billing. Question 30. Which of the following is an example of an unethical coding practice? A. Querying a physician for clarification on ambiguous documentation. B. Reporting codes for services that are supported by the medical record and meet medical necessity. C. Assigning codes that are not supported by the medical record in order to maximize reimbursement. D. Participating in continuing education to stay updated on coding guidelines. Answer: C. Assigning codes that are not supported by the medical record in order to maximize reimbursement. This question directly tests the understanding of ethical coding principles. The core concept is that coders must always assign codes that accurately reflect the patient's condition and the services rendered, based solely on the documentation in the medical record. Assigning codes that are not supported by the documentation, especially to increase reimbursement, is a fraudulent and unethical practice. Querying the physician for clarity, accurately reporting services, and ongoing education are all examples of ethical and best coding practices. For example, if a procedure was performed via open approach but coded as laparoscopic to get a higher payment, that would be unethical. Always prioritize coding accuracy and integrity over financial gain.